Greetings and welcome to the first of a series of webinars dedicated to the teratology elements in clinical practice. At this point, I wish to call your attention that each webinar has a companion supplement with emphasis on visual elements. Here are shown the series of webinars. We start with an introductory comments and an overview, followed by clinical teratology, teratogenesis, dysmorphology, following which a basis is established to initiate a series of clinically oriented webinars, topical subjects such as the impacts of alcohol, radiation, etc. These materials are produced through the partnership of MedWord LLC, OmniNet, and members of the Ukrainian OmniNet teams. The editor is Vladimir Werteleki, described in the next screen. Note that the supplements present visual elements that are included in examinations required for certification of participation. Here you could read about the speaker, and in the context is shown the symbol of Clinical Eye Openers, a website that is from which most of the materials are extracted, mainly visual, and the principles sustained by OmniNet, which is then the emphasis on vision, mental, not just physical, an emphasis on clinical arts that is providing sustenance to those impacted and their families based on scientific facts and combined with medical ethics. I will underscore that the written contents of these screens sometimes cannot be fully read in the time allotted in the interest of brevity. So I advise of those who wish to read more leisurely to stop the motion and do so. Here are then the companion website containing the material summarized in this series. This is the emblem of Clinical Eye Openers, and it's a combination of emphases on dysmorphology, teratology, genetics, etc., which will be addressed shortly after. Here's the emblem of the organization and its ideals. Also an emblem of a teratology information system in a vernacular language, in this instance Ukrainian, a system that provides extracts of literature facts, particularly crafted for clinicians, and Pandora Word Box, which emphasizes terminology, its roots, etymology, etc. You can visit these websites by using these links, where the nature of clinical eye openers, the nature of the network, and the teratology information system, the birth defects international information system, and the terminology and ideonomy, that is the name of ideas, are exposed in the Pandora Word Box. Shown here in schematic form is the challenge we face in presenting these 4 webinars. First of all, it is a reiterative process of emphasis of the practical aspects of clinical practice, that is, eye openers, showing visual expressions to increase the sensitivity of the vision of clinicians. And concurrently, the presentation of ideas, notions, terminology, which in turn sharpen the interpretation of signals and increases the number detected and more ideas. So this iterative process is essential and has to be presented as concurrently as practical. The other point is that signs are the only fact The rest are interpretations. The rest are hypothetical. A cleft lip is a lip, is a lip, is a cleft, is a cleft. But a signal of what does that cleft lip means depends on how much practice you have to notice the nuances, left, big, small, and what are the basic sciences teaching us about the causes, mechanisms, prevention, treatments, and so forth. So, terminology, definitions, and interpretations are temporary and reflect the status of knowledge. Etiology sometimes can be objective, but most of the time is hypothetical. For instance, Down syndrome, we say, is trisomy 21, maternal age, but what is truly the etiology of chromosomal non-disjunction remains elusive. Pathogenesis is the mechanism. Mechanisms can be multiple. We may know some and we don't know others. The fit is never 100%. And the definition of syndromes is fluid. It depends on the number of patients, knowledge of ethnic backgrounds, etc. The natural history is the second objective element that cannot be argued with. The patient is dead or is alive, is well or is not well. But prognosis is far more limited as it is currently used in clinical medicine. I must stress here that in these webinars there is not enough time, nor is it within their scope, to emphasize diagnoses, treatments, prevention, and so forth. Should the viewer be interested in these aspects, they should seek additional information in standard sources of medical literature. So, here is then this warning that the contents in these webinars should not be relied upon for the formulation of diagnosis and clinical management. So what do we know about clinical teratology? In general, then, it can be said that most clinicians have a fairly dim idea of what this term implies. And as just stated, the scope of ideas and practical aspects that they should be aware about. So I would like then to start by clarifying this dark background, by emphasizing that clinical teratology incorporates knowledge from experimental teratology and pathologic embryology, as well as the discipline of dysmorphology, the ability to conduct extended and specialized physical examinations of patients for developmental landmarks, including those from prenatal life. Therefore, clinical teratology is larger than just medical genetics. It includes it. And it's larger than reproductive toxicology or pharmacology. It includes it. So, clinical teratology is in fact an amalgam of these basic sciences. Anything that is relevant and helpful to a patient is incorporated in this mode of clinical practice. And therefore, that includes the components, let's say, of human and medical genetics, of chromosomal imbalances, gene mutations, and then how radiation may change these, or how radiation can damage directly the developing embryo fetus, just like mercury or arsenic. More recent and more subtle are the impacts of malnutrition, micronutrients, and medications, which enter the market by the hundreds and pose a growing number of threats, since over 50% of pregnant women are consuming some sort of medications. And as we go on to clarify the background of what clinical teratology is, we must add to its fold dysmorphology. This is virtually a newborn in clinical medicine. There are virtually no formal programs to train clinicians in dysmorphology. These 4 webinars attempt to fill this gap to some degree. to help clinicians understand the scope of all of these advances in instances of sterility or recurrent miscarriages or structural malformations or functional malformations, which are far more common than physical ones, to understand that not all is genes, not all is teratogens, some are mechanical, like deformation, and many of these factors are manifested later in life, where the repertoire of manifestations tend to very often be cancer. So this is then what we attempt to expose the listeners over the next 4 webinars. And because we like to be practical, we start then with one of a series of clinical videos. This one is a master class by Professor Kenneth L. Jones, who then discusses the specialized aspect of how to develop an infant for developmental landmarks. Landmarks that are important to grasp as far morphogenesis or its disruption, that is dysmorphogenesis. Please note that this is the first of 4 clinical videos that Professor Jones offers to us. And who is Professor Jones? You can read this by stopping the motion, and next will be then the video itself. Please try to remember the key points that Professor Jones emphasizes.
I'm Dr. Ken Jones, and I'm going to do a physical examination on this 6-week-old little boy. I want to start off here, this examination, right at the top, and I want to talk about head circumference. So oftentimes you will read the chart, and on the chart you will note that the baby has a head circumference that's very small. And if you, I want to stress the fact that if you are concerned in any way about a head circumference, you've got to do the head circumference yourself. And the same thing is true as far as the length of the baby. So first, the head circumference. Again, you take a cloth tape. I like a cloth tape. You can take a paper tape, although the paper tapes frequently are not very accurate. And you give the baby as big a head as you possibly can. And obviously, because of the molding, head circumferences in the newborn period oftentimes are not as accurate as they are at 6 weeks of age, but Liam here has a head circumference that's well within the normal range, and this is the way you do that. Now, as far as a length is concerned, and I want to make the same point as far as the length is concerned. Liam here is 6 weeks old, and he's incredibly content and happy. Oftentimes in a newborn baby, they are still in the position that they were in utero. And therefore their legs are pulled up and they're all contracted and they're screaming and they're yelling. And the nurse has had to do the measurement on her own or his own. And I will tell you that that's an almost impossible measurement to do by yourself. And the reason is that you've got to straighten out the legs, you've got to get the tape in a normal position, and then you've got to read that tape, and you've got to get the baby's head right, and it's really impossible. So measuring a baby is a 2-person operation, and it's frequently even a 3-person operation. And that's true for a lot of the things that you do on a newborn baby. So the way I do it is I get somebody to help me, and Tina's going to help me here, and we get his head as straight as possible. And Tina, can you hold his head, the tape down here? Good deal. You do it? I know, bud. Just hold that. Perfect. And then I pull the tape as tight as I can, straighten out his leg, and his length is 57 centimeters. So I just want to stress there that those 2 measurements are 2 measurements that oftentimes are off. So I'm going to start here at the top, and we're going to talk about his fontanelles and sutures. A baby has a number of sutures and has 2 fontanelles that are quite obvious at this age. The sutures are a metopic suture here in the front, which is a vertical suture that comes off this end of the anterior fontanelle, which is a diamond-shaped fontanelle, and it's right here. And his is closed, which is completely normal. And then there are two sutures here, and they're called coronal sutures. Then there's a sagittal suture that goes back here to the posterior fontanelle, which is triangular shaped. And then there are two sutures down here which are called lambdoid sutures. So the sutures, interestingly enough, are a little bit different in terms of the way they're configured, because the coronal sutures, unlike the sagittal sutures, are beveled. And so the coronal sutures slide together like that because they are beveled, and they allow the head to mold very nicely as the baby comes down the birth canal. The sagittal suture is squared off so that it does not bevel, they don't slide across each other, and they come together like that. And so frequently you can feel a ridge here, which is a function of the fact that those sutures are together, and you can feel, because one's riding higher than the other in some cases, and that's not the case with Liam either. So that's nice. So here's his anterior fontanelle. His posterior fontanelle is way back here. And as I said, there are two lambdoid sutures that come off that. Alright, now the next thing that I want to show you is his posterior parietal hair whorl, which is right here. It's to the right of the midline. And the normal position for the posterior parietal hair whorl is within 3 centimeters anterior to the posterior fontanelle, and within 3 centimeters to the right or to the left of the midline. So he has one posterior parietal hair whorl. The vast majority of people, about 97%, have a single hair whorl. Close to 3% have two hair whorls. A very few number of people have more than 2 posterior parietal hair whorls. Nobody who is normal has no hair whorls. So the posterior parietal hair whorl is a reflection of the underlying brain at 16 to 18 weeks of development. So the way it works is that the brain during that period of time has most of its growth in a posterior fashion. So it pushes back in a dome-like fashion, and the skin at that time is pulled around that brain as it grows back. And the point of maximum stretch on that brain as it is, or the maximum point of stretch on that skin as it is pulled around the developing brain, as the brain grows back in that dome-like fashion, is the point where the hair whorl forms. Now, you also have to understand that the hair root starts to form at about 14 weeks, and the hair extrudes onto the scalp at about 16 weeks. So that's the point where the maximum stretch comes on that skin as it is pulled around the developing brain, and that's the point where the hair whorl forms. So the hair whorl is a beautiful representation of what the brain looks like around 16 to 18 weeks development. So a normal posterior parietal hair whorl, which Liam clearly has, is a reflection of a normal brain at 16 to 18 weeks of development. Now I'm going to move forward from here to the ears, and we're going to talk about the position of the ears and the configuration of the ears. And as many of you are probably aware, people are always suggesting that babies and older children have low-set ears, and I just want you to know that it's very rare for a baby or anybody to have low-set ears. Many people think when they are trying to determine whether an ear is low-set, they think that what you do is run a line through the inner canthus to the outer canthus, and then run that line around the side of the head and determine the position of the ear based on that line. But if that was the case, every baby that had upslanting palpebral fissures would have low-set ears, because that line would go up like that if the palpebral fissure was upslanting, and everything would be below the line. If a baby had downslanting palpebral fissures, the opposite would occur. Nobody would have a low-set ear. So the line that you draw is through the 2 inner canthi of the eye. They're the fixed points of the eye, and you take that line around the side of the head, and 20% of the ear should be above that line. Now I want to say something about the size of the ears as well, because they can be particularly important, particularly in terms of making a diagnosis of Down syndrome. So in fact, a small ear is probably the best and the most constant sign of Down syndrome, obviously, other than an extra chromosome 21. So the way you measure the ear, and it's important that when you start measuring things that you have a stiff ruler. Mine is metal, but you can have a plastic ruler or a non that is clear, or one that is solid in terms of its color. And when you're measuring the ear, and I'm just going to demonstrate this if I can here, you go from you make the ear as big as it can possibly be. So you go from the bottom of the earlobe to the top of the helix, and in his case, he's got pretty large ears. His ears measure 3.8 centimeters. So in the newborn period, the smallest ear in a full-term baby, and this is true in both Mexican-American babies and Caucasian babies, in which we've done these measurements, and we don't have measurements in anybody else, but in Caucasian babies and Mexican-American babies, the smallest ear size is 3.2 centimeters, and the largest ear size is, in a child with Down syndrome, is 3.4 centimeters. So there is a very slight overlap between 3.2, which is the smallest ear size in normals, and 3.4, which is the largest ear size in kids with Down syndrome. But children with Down syndrome usually have ear size down around 3 or 3.1, and babies that don't have Down syndrome generally have ear size around 3.8, 3.9 centimeters. So this is a very, very good sign of Down syndrome. So if you think that you see a baby who has Down syndrome, the first thing you want to do is measure those ears, and if the ear size is, say, 3.6 centimeters, almost always you can forget about a diagnosis of Down syndrome. So that's the ears. Right, now I want to talk about the eyes, and the intercanthal distance is a measurement that is done from the inner corner of one eye to the inner corner of another eye, the other eye. So it's just a simple measurement that goes from one inner corner, or one epicanthus to the other epicanthus. So his intercanthal distance here is 2.5 or 2.8, which is completely normal, and he has a very low nasal bridge. So all babies have a low nasal bridge, but Asian babies have particularly low nasal bridges, and it's interesting that to think of the lowness of a nasal bridge as far as a baby is concerned. Because if you are a cartoonist in a newspaper or whatever, and you are trying to create an individual who is very cute and very attractive, you put their eyes far apart. And if you want to make somebody look sinister and evil, you put their eyes close together. That's sort of snake eyes. So the thing that really makes your eyes, or that you can make eyes look far apart, is if the nasal bridge is low. So what happens, babies are born with a very low nasal bridge, and it looks like their eyes are very far apart. They're not so far apart, but it makes them look far apart. And because of that, maybe not because of that, at least not because as far as their mother is concerned, but one reason that that is the case is because their nasal bridge is so depressed. And then with time, as a baby grows, and then when the baby hits adolescence, the nasal bridge grows forward, and it brings their eyes together, and they clearly, at least to themselves, start to look very odd and very sinister. So babies have very low nasal bridge, and it really adds dramatically to how cute that they look. So the palpebral fissure length is another measurement that is very helpful in terms of your thinking about a newborn baby. And this is clearly the most difficult measurement that you can possibly make. So the palpebral fissure measurement is made from the inner corner of the eye to the outer corner of the eye. And so this is the way you do it. And it's particularly hard in a baby because they don't like to open their eyes and they don't listen to you. But the normal palpebral, but what you have to do is spend a lot of time. And Liam here is being very cooperative with me. And I've already figured that his palpebral fissure length is about 2 centimeters, which is really completely normal palpebral fissure length in the newborn baby. It actually goes from about 1.8 to 2.0 centimeters. And the palpebral fissure, from the standpoint of its normal development, is a dependent structure. So it depends on the optic vesicle, or the eyeball. So the eyeball is an outpouching of the frontal region of the brain. So the optic vesicles come forward and they induce the palpebral fissure. So the size of the palpebral fissure is a function of the size of the optic vesicle and the position of the optic vesicle, which is determined by the frontal area of the brain. So anything that affects the frontal area of the brain can affect the optic vesicle, make it abnormal in terms of where it is going to go out and induce the overlying ectoderm to form a palpebral fissure. And it also is critical because if it's smaller than it should be, it induces a smaller palpebral fissure. So again, like the hair whorl, the palpebral fissure can be extraordinarily helpful to you in terms of giving you an idea what early brain development was like. So the philtrum also can be very important to you in giving you some idea about what the underlying brain looks like. And the philtrum is the area from the base of the columella, which is right here, to the vermilion border, which is the top of the vermilion border, which is right there. And this area, as you can see here on Liam, has these 2 vertical ridges. So those 2 vertical ridges are completely normal structures, and Liam has a completely normal looking philtrum. The important thing for you to recognize is that that area of the face comes from the medial nasal processes of the developing frontal area of the brain. So the nasal processes are the area where the nasal pits are going to be. Nasal pits start around the side of the head, and the medial processes, or the medial area of those nasal pits, is the area of the frontal area of the brain where the philtrum, this area, comes from. So as time goes on during facial development, those nasal pits come forward like this, and they obviously reach almost to the midline, and that area that is going to make up the philtrum is pulled around with those nasal pits. So if there has been an insult to that area of the developing brain, either some kind of a structural or an environmental or a genetic insult to that area of the medial nasal pits, then there can be a problem with development of that philtrum, and the problem that generally speaking develops is that there is a lack of those vertical ridges, so that the philtrum is completely smooth. And that's the case in a number of structural defects like holoprosencephaly, where there's a defect in early brain development in the frontal area. It occurs with the fetal alcohol syndrome, and one of the major areas that alcohol affects is the frontal area of the developing brain. And so by virtue of having that insult to the medial nasal processes, the philtrum is very smooth in both of those disorders. Now I want to talk about the hands. And the hands can also be very helpful in telling you something about early brain development. So if you straighten out the hands, and obviously in a baby they have their hands clenched, so it can be difficult to straighten a baby's fingers, and one of the tricks in terms of doing that is to flex the baby's wrist, because if you have the baby's hands like this and you try to extend, it's much harder than if you have the baby's hand like that. So if you straighten the hand, what you, first of all, looking at the palm, he's got 3 creases on his palm. So he's got a thenar crease, which is that. and then he's got a proximal and a distal palmar crease. So that's completely normal. Those creases are due to movement of the fetal hand between 8 and 10 weeks gestation. So again, we're talking about brain development, because if a child has a problem in early brain development, they're not moving adequately, and if they don't move adequately, they frequently have abnormalities of their crease pattern. You know, a mother, when you ask her when the baby started moving, she will tell you generally she started feeling the baby at about 18 to 20 weeks gestation. However, a baby starts moving long before that, and the baby starts moving by 8 to 10 weeks at least, and those crease patterns are a function of that. So the thenar crease is a function of that movement of the thumb. And the proximal and distal palmar creases are a function of the fact that our palm is not completely square. So if our palm was, well, our palm folds in this direction and it folds in that direction by virtue of the fact that the fourth and fifth metacarpal bones are shorter than the second and the third carpal bones. So by virtue of that, the hand folds like this, and you get these two palmar creases. So in Down syndrome, babies have a single crease across here in about 40% of the cases, and the reason for that is that the fourth and fifth metacarpal is the same length as the second and third metacarpal, and by virtue of that the palm is square, and by virtue of that when the palm starts to fold at 8 to 10 weeks, it folds like a door on a hinge, and you get a single crease across here. So that's the palmar creases, and then the interphalangeal creases also can be very helpful. And so you can see that he has a proximal and a distal interphalangeal crease on each one of his fingers, and that's completely normal. And again, the creases in the interphalangeal region can be very helpful in terms of the same thing, fetal activity. So if you have a baby who has contractures of the fingers, and that baby has crease abnormalities on the fingers, that tells you that those flexion deformities of the fingers occurred prior to 8 weeks gestation, prior to the time that the crease pattern formed. So it can give you not only an indication that there was a problem in fetal activity early on, but it can also give you an idea when that problem started. So if you see a baby with contractures of the fingers and missing creases on the fingers, that's called camptodactyly, C-A-M-P-T-O-D-A-C-T-Y-L-Y. And if you see camptodactyly, that tells you that it doesn't give you a diagnosis, but it tells you that that baby was not moving its fingers, or his or her fingers, prior to 8 to 10 weeks gestation. And it could be due to a neurologic problem, it could be due to a tendon problem, it could be due to a bony problem, but it behooves you when you see that to say, all right, this baby had a problem with early movement, and the question is why. Next we're going to look at Liam's chest and just look at a couple things here on his chest, actually just one thing on his chest. And I want to talk to you about a structure that you probably don't think about very much, and you probably don't think about it particularly with respect to measuring it. And so what I want to talk about is the sternum. So the sternum is measured from the sternal notch up here to the tip of the xiphoid down here. And the only thing to be aware of in a baby is the length of the sternum. So the sternum should be equal to 1/3 of the distance from the sternal notch to the symphysis pubis, or more than that. So you measure it by, we'll just slip this, undo this here just a little. The symphysis pubis on a baby is beautifully marked by a horizontal crease. So the top of the symphysis pubis is right there. So let me just take my tape measure here, and we'll go right from the top. Thanks, where's that, Tina? Thanks. We'll go right from the top of the symphysis pubis, or right from the top of the sternal notch to this horizontal crease here, and that's at 22 centimeters. And then his sternum is 7.5 centimeters. So that's quite a bit greater than 1/3 of the distance from the sternal notch to the symphysis pubis. So his sternum is a perfectly normal length. Let me just get him back together here. Completely normal length, and the reason I bring that up is because it is a very nice diagnostic sign of trisomy 18 syndrome. It's a syndrome that we in pediatrics in the newborn period don't see very frequently anymore because most of those babies are diagnosed prenatally, but it's something always to keep in mind. Now, I just want to mention one other thing before we finish with Liam, and that is looking at the palate. There are many people that will tell you that you can determine whether a baby has a cleft palate by sticking their finger down their throat. And I can't tell you how wrong that is. You will miss a substantial number of babies' cleft palate, and definitely a bifid uvula if you do not stick a tongue blade down there and get a light and look. And I'm sorry, Liam, I'm going to have to do that just to demonstrate this, but I've kept it to the last, and that's an important thing always to do, because he's not going to like this. So you really, a baby's throat is such that you really have to get it down there and all the way back, and you can see, or at least I could see very nicely, that his palate is completely intact, as is his uvula. So you can say without any question that this baby does not have a cleft palate or a bifid uvula. So this concludes what I'm going to go over as far as a physical exam today. Obviously, there are a number of other things that are critically important to do when you do a physical exam, like listen to the chest and check for hip dislocation and a variety of things like that. But what I thought I would like to do is to go over some things that represent minor malformations, and particularly those minor malformations that you can see on an external examination of the baby that can give you an idea about brain development, because that clearly is the thing that's most important to document or try to document in the newborn period as early as you can. And so if you pick up some sign here that is altered that I've been showing you today, that's a baby that needs to go under the microscope so that you can follow that baby carefully from the standpoint of his neurologic and intellectual and cognitive development. So thanks a lot.
I hope you enjoyed the video by Professor Jones. As all visual exhibits, video or galleries of images, they try to convey forget-me-not points. For instance, in Pandora, forget-me-not will lead you to the emblem of this concept, a little beautiful flower. These are what some may call a string of pearls, but in any event, these are observations of considerable importance to clinicians. It's like a treasure box, Pandora word box. From that video, it should be clear that it is an imperative for clinicians to always record the head circumference, their own measurement, not relying on passive records, and to plot it to ensure that it is within the norms for that particular sex, population, and age. Routinely, one should seek a hair whorl. Virtually, there are no people without a hair whorl on the scalp unless they have severe disruption of brain development. Generally, the hair whorl should be within 3 centimeters of the midline. The auricle size varies, but small auricles, that is external ear, are one of the most consistent signs of Down syndrome. Here is an example of what I call reverse signs. If you have strong suggestions that a baby has Down syndrome, but that doesn't have small auricles, you should be very, very cautious. It may be a look-alike, and therefore there are some signs that are warning if they are absent. Ocular fissures should also call your attention. You should watch and record in your records if there is a slant and if the size is unusual. It should be always measured and plotted against norms because it reflects the size of the ocular globe, which in turn reflects the development of the forebrain. The philtrum of the upper lip is a very important area to note normality or distortions of normality. And they again reflect the development or alterations of the forebrain. Palmar and digital flexion creases are related to motion, early motion, motions within, let's say, a few weeks after implantation of the egg, and they reflect then the neuromuscular developmental status. Very useful markers. A small deformed sternum is very frequent in a variety of syndromes, and therefore if you see this, you should wonder whether indeed is one of the components of a syndrome that you may have not noted yet. And I have to add of what was not stressed particularly in the video, the skin. Any spots of the skin are informative until proven otherwise, whether they are pink, bluish, brown, or discolored, or white, whether they are multiple, single, it doesn't matter. You should notice them. And if you don't know, certainly access to dermatologists and other specialists is generally available. So here we reach another screen that you may read by stopping the motion in more details. But this is an example of amalgamation of signs that you may interpret as signals if you have an idea of what the signs may imply, and if you have an idea of what would be the recognized label for that sign. So what is a teratogen? What is a mutagen? I think most listeners know that mutagens are any agents that can alter the genomic plan. But what's a teratogen? Mutagen can also alter the development of the fetus, but teratogens are far more general concept. It's any environmental factors, any whatsoever, mutagenic or not, that can change for the worst the development of an embryo fetus. So all mutagens during prenatal life are teratogens, if indeed it is prenatal, because after the body is formed, the repertoire of mutagens is no longer in the sphere of teratogenesis, but falls into the sphere of neoplasias and so forth. Some teratogens are mutagens, indeed, radiation is. But other teratogens are not necessarily mutagens, for instance, alcohol. So these contrasts are important to keep in mind. And what is dysmorphology? Dysmorphology then will define as the study of altered morphogenesis and will add altered function, which is the consequence of an altered morphogenesis. So they can be then these signs functional or structural. Whether they are signals depends what you know, and whether you can cluster them into a syndrome, that is a basket where the etiology or the mechanism are shared. That again depends on your experience and knowledge. But signals, syndromes, pathogenesis, etiology, diagnosis, these are subjective, they are always temporary, and you should be willing to reassess these as new signs emerge. Natural history is somewhat neglected in clinical life. It can be also called catamnesis, meaning the fate of each patient. It reflects the environment of the patient, the family, the village, the population in which it belongs. This is then the domain of clinical epidemiology. And why do we mention ethics? Well, very quickly. These are then conjoined twins. What about if they are the result of artificial insemination or some manipulations called reproductive technologies? Some of these conjoined twins are born and they have normal intelligence, but is that what they wish? Is that what those parents wish? What is the ethics of manipulating fertilized cells and then ignore the consequences? Here is an example of Down syndrome. She is maturing, she is ovulating, she may be fertile. Who has the authority to say sterilize, sterilize? Can she make that choice? These are the ethical dilemmas that you will be confronting consistently, because teratogenesis and ethics are very, very close to each other. So, what is then health? What are we after? We are then after sustaining health. What's a short way of thinking of health is homeostasis. I am I want to remain I don't want to be changed. So, what is I? What is normal? Ego sum, but ego sum is not enough. I am what my circumstances allowed me to be or allow me to remain. So, without environment, without a family history, etc., you cannot really fully grasp what is the prognosis, that is, what is the fate, what's the catamnesis of this patient. Is she going to have Alzheimer? Is she going to have leukemia? What? So each patient is unique, but to what extent is unique normal or just what we call a variant or variability? This is then when the statistics and mathematics come in and very often lead to conflict. So we mentioned the amalgam, and we mentioned how the amalgam includes this. And as business invades clinical world and clinical decisions, it also poses strong ethical questions. Who has to benefit first? The business of the doctor or the need of the patient? And who is the arbiter? That's why physicians take a Hippocratic oath. So here we are then going to tell you that trisomy 21 is a well-known disorder. It is well known to you. It is associated or manifested as Down syndrome. But there are some extra points I want to make. You know that normally we get one chromosome from the father and another from the mother, and all total we get 23 from each, so we have 46 chromosomes. We are diploid. We have 2 genes of each kind in these chromosomes, so we have disomies. And occasionally we have 3 chromosomes, we call them trisomies, or if we have 3 chromosomes of each kind, we call them triploidy. This is not viable. This is to a large extent viable. To what extent? Do you know? That's why when you don't have a family reproductive history, you're cutting your own nose. You're half blind. Another issue is that this is due to non-disjunction in the process of fertilization, but it can happen somatically, it can happen in body cells. And let's say that this is a mosaicism. Most cells retain 46 chromosomes, but one slips up and has 47. And let's suppose this happened after birth. Does that mean that an individual, like the President of the United States, all of a sudden is metamorphosed into an instance of Down syndrome? Obviously not. So you cannot compare the process of mosaicism automatically. With phenotypes, it depends on the proportion and depends when it arises. But, for instance, in neoplasia, this is a fairly common phenomenon. So we know that most trisomies are lethal. This is an exception. Trisomy 21, we know very well that there are many survivors, but in most instances they are lethal. That is what we just call teratothanasia. But again, if you don't have a family history, you're cutting your own nose. And here is a fairly simple then graph From preconception to birth, from birth to development, childhood, adulthood, senility, there is a satellite track, is the fertility of those who survive. The survivors are a given proportion, but they are never 100%. This process before birth we call teratothanasia, and later on we call them neonatal mortality, infant mortality, childhood mortality, and so forth. So what is the proportion of the eliminated? Well, examples are not so simple. The more we know basic science, the more we add to these equations. And it's interesting to know then that you already know that the most sensitive cells are those of the early embryos and that they are capable of total regeneration, for instance, making a twin, and regenerations without scars. And then later on, that's lost. We don't regenerate an amputated leg, but we can generate scars, repairs, and survive. Or if not, it adds to mortality. This process of selection across time is then what we call teratology up to the point of birth. But the manifestations along the way are different, from infertility to spontaneous losses of pregnancies, malformations, tissue dysplasias before birth, which involve a whole category of tissues, or after birth, which may be cancer. All of this process has to be taken into account. So let's accept for the argument's sake that teratothanasia is over 5%. It's certainly over 5%. But statistically, we define 5% as something that is normal. 5 or more percent, we say we arbitrarily define this statistically as normal. And this is where statistics begins to enter into conflict with real medicine. Is death normal? That's sort of hard to believe in the medical perspective. The first 2 weeks are highly risky for the conceived individual. Many don't implant, those do implant don't do so successfully. Many embryos do not develop a normal placenta or implantation of the placenta, and so forth. These early anomalies we need to take into account, and among the earliest is the monozygotic twin. As perfect as it may be, it is not within the norm. And some of them remain conjoined. The early anomalies include spina bifida and many others. So, again, reproductive history. If you don't take it, you don't know it, you cut your own nose, you are not a good detective. So let's look at some facts. Spontaneous pregnancy losses, if they are recurrent, they are due to at least 50%, some studies show, but let's accept that at least 15 to 20% of women lose a pregnancy here and there. And 50% of those that are lost have chromosomal anomalies. But then we also mention the issue of ethics. What has that to do with ethics? These are conjoined twins. What has that to do with ethics? This teenage girl with Down syndrome. Well, here, then, maybe this is the result of artificial insemination or other techniques such as reproductive technologies, which is a euphemism. They produce anomalies. Who pays the bill? Not in dollars and cents. If something goes wrong, the bill is paid by the living child, and many of these conjoined twins are compatible with life, but they wish to be like you and me and not stuck with each other. So what is the ethics of the business of reproductive technologies? Where is the number one loyalty? To the profit sheet? And why is it that it's so hard to get statistics of the results of these technologies? They consider a pregnancy success. Would you call this success? Here we have an issue that this child is already becoming a young woman and she is menstruating. Should she be sterilized? What is her risk to have problems? What is the risk? Not to her, but to her child. Would a child like to be born and have a mother that is mentally abnormal? What about the short lifespan? A child that is born that becomes an orphan, who's going to raise the child? She cannot raise a child. Who could say sterilize her? Who has the authority? This is the example that teratology and ethics are virtually always intertwined. So let's return to blastopathies. As long as the fertilized egg develops on the basis of maternal genes, because those of the father have not yet opened up and are active, the cell doesn't grow, it divides, but it remains of the same global mass. The mass of cells begins to increase as the genes of the father become active, and the very first function of that rapidly exploding blast, like an explosion, the blasto cell, the blast, is the developing an axis, a tail and a head, right and left, front and back. But very often, instead of one, there are two axes. And then monozygotic twin arise. Are they exactly identical? Not really. Because although they may have exactly the same genome, the environment of one is not the same like the other. So that if this one has anomalies, this one doesn't. If this one does, this one doesn't. So the concurrence of anomalies in both of the twins is rare, which talks about other factors, not genomic factors. So look at the kind of anomalies that monozygotic twins have, and generally you're going to find that they are discordant. Why are they discordant if they have the same genes? Sometimes they are conjoint. Why are they conjoint? Well, they could have been stuck and didn't separate, or they may have been separated and became conjoined because the tissue compatibility is absolute. Sometimes they are virtually symmetric, sometimes they are not. And sometimes this smaller one disappears and you have a single child. Is that normal? Or is the dying fetus impacted the development of the survivor? That is one of the topics that Dr. Ken Jones did present or will present in this webinar or the subsequent ones. The impact of this sort of destruction mechanism, disruption. So to recapitulate then, you have dizygotic twins, two separate genomes, two separate children. But you have monozygotic twin, two axes, two individuals, sometimes conjoint, sometimes asymmetric, sometimes the asymmetry disappears, and that's called the vanished twin syndrome. But these twins are not necessarily normal. So how do we know there was a twin? Well, let's turn the pancake upside down. If you have a child with certain anomalies, ask yourself if it is the consequence of one twin that once was and no longer is. And with ultrasound, more and more pregnancies reveal the presence of twins, but at birth there is only one left. So think of early anomalies. They are highly lethal and yet compatible quite often with survival. And I also mentioned the rather unique characteristic. Here you have an embryo that is covered by amnion, a membrane, and is living inside of a cavity lined with amniotic epithelium. But occasionally, for reasons unknown, this barrier is broken and a portion of the fetus is exposed to the highly vascular aggressive tissue of the chorion. So this embryo is no longer protected in these body parts, and what results then is a severe form of destruction or disruption. And the only way to be sure is that study cases more and more and more that are incompatible with explanations of genomic alterations, chromosomes, teratogens, or whatever. Here, to have this normally formed eye implied that you have to have a normally formed forebrain. This is already not there. This has been digested out. And we have a living example of a beautiful child with a normal mind. She grew up, she finished high school, she's multilingual, she's as smart as any other child and has a perfectly normal leg, but the other one is gone, is digested out. What possible mechanism could this have been? This is how clinical teratology contributes to basic sciences, because these tissues very often become then neoplasia, and if you look at them, they are very similar to teratomas. And one thing leads to another, so that these signs then become signals of processes that we did not suspect existed. On balance, clinical teratology, in my view, contributed more to the advances of molecular genomic knowledge than the vice versa. And to return the importance of the family, clusters. Family is a cluster of individuals, a cluster of genomes, and a cluster of ecology. They share these elements, genomic and ecologic. And here you have then a twin that is conjoined, stuck at the thoracic area, and spina bifida, a concurrence. Here you have spina bifida, here you have spina bifida, here you have one family and another family, and you have twinning here, and you have twinning here and here. What does that mean? Anything? Oh, I don't know. Just two cases don't make science. But I do know a lot of families. Surveillance process of all children with developmental problems, we begin to find twinning, and twin here, and twin there, and twin everywhere. These are neural tube defect associations with twinning. Well, what has twinning to do with an open spine? Well, that's a scientific issue to be addressed or confronted by scientific methods. But who will call the attention of the vigilante that there is something wrong in this neighborhood? Is the clinician, and that's your responsibility. And once you have such findings, like shown just a few seconds ago, you should share that, not be selfish. The Hippocratic Oath says that physicians are supposed to share. They're supposed to have disciples that get the discipline. And you ought to be aware that monozygotic twinning is not a normal event. Some end in conjoined twins, and then the question arises, is there a relationship with the teratoma? Is that tumor a degenerated embryo that doesn't look any longer like an embryo, but it has all the tissues of an embryo? Ectoderm, mesoderm, endoderm. That's the definition of a teratoma. Where does that come from? So these schema that I'm showing you here are down very simple to understand, that there is a process of damage, resistance, which is the balance of how much regeneration repair occurs as to what is persistently disrupted, and then whether this situation, the balance sheet, is so bad that it will end up in teratothanasia or is going to end up in the life of an individual that is normal or almost normal or not normal. And here you have then the contribution of fine arts. Artists have very sharp eyes. They know this child is not normal. But a clinician is the only one who will recognize that this child is at risk of renal tumors simply because of the cluster of these signs that a clinician is capable of interpreting as signals of particular risk. A signal of particular risk for leukemia, for Alzheimer. A signal here for sarcomas because there are these benign tumors and a sac. And in terms of this, the fire from the sky is Chernobyl. What happens in Chernobyl? Well, this is what we suspect may be happening, and that is an impact on blastopathies. What blastopathies? Well, conjoined twins among others, and then neural tube defects. So this schema now is so simple that it's almost offensively in terms of too simple. And now it's time for you to read the principles of teratology by stopping the motion and cogitate, think what each of these principles is telling you. If you understand them, your practice of clinical medicine will be enhanced. Welcome to this short presentation of teratology principles. This presentation should be read. The oral comments are minimal. I like only to share with you that there is no spontaneous generation in the progress of science. During the 19th century, studies of embryology and embryologic pathology led to the flourishing of teratology. And from there, it moved into clinical teratology. James J. Wilson was a collaborator of Joseph Workany. Joseph Workany was the first to conclusively demonstrate that environmental factors can be a cause of congenital malformations. Up to that point, the dogma held that congenital malformations had to be genetic in nature, and much of such view persists. Thus, the principles of teratology are fundamental and distinguish this new clinical science from generalities of toxicology. The first of the principles underscores that the susceptibility to a teratogen reflects the genotype not only of the fetus, but also of the mother and the interplay with each other. It is known that diverse species are more or less sensitive to different medications, toxins, and teratogens as well. This was one of the problems with thalidomide. This drug, when tested on conventional experimental animals such as rats or mice, would have not detected the teratogenicity of thalidomide. This is a note of caution. When new drugs are being marketed and tested on one or two species of animals, there still may be a missing detection of teratogenicity. The ultimate proof of teratogenicity is whether there is demonstrable harm to the human embryo. The susceptibility also reflects the sensitivity or resistance of a particular organism, tissue, or developmental system. That, in turn, reflects the capacity to regenerate completely without evidence of harm, or repair which may be relatively perfect or imperfect. Just remember that congenital malformations very often are more frequent in males than in females, and that in itself indicates a contrast of susceptibility. Permit me to remind you that you should read what is stated in these frames. The comments are secondary and minimal. You can stop the motion to read at leisure. We spoke of susceptibility and will continue here. Susceptibility then also reflects the stage of development. There are refractory stages of development. Certain tissues don't even exist. Or once a development is completed and the cells are not dividing, then the action of teratogen may be limited. So organogenesis in general is portrayed as the most sensitive period in regards to the formation of malformations. I like to only remind you that blastopathies, which is a stage of very early development before the implantation of the embryo, is of great interest in the study of congenital malformations. Anencephaly has something to do with the formation of the axis of the human body and a failure of the development of the cephalic end of what will become the spinal cord. Conjoined twins reflect a problem earlier than this. It is when one egg forms an axis and then by an anomaly forms a second one. So please read at leisure and consider these points. Again, here I stress that male and females are distinct. Blastopathies as a group are prevalent in females. This principle is most important because it distinguishes teratology from generalities of toxicology. Unfortunately, we have terms like reproductive toxicology. So pay attention to the fact that the pathogenesis triggered by teratogens is specific and not general. For instance, thalidomide rarely impacts cerebral development, and if so, it does minimally. And so does alcohol develop certain developmental pathways to the extent that we can clinically diagnose fetal alcohol spectrum disorders. If the impacts or pathogenesis were at random, then clinical teratology would not exist. This principle brings us to the manifestations, the phenotypes. And it is important to remember that this phenotype spectrum is not only reflecting a particular teratogen, but also when it did act and on what sort of sensitivity and repair capacity acted upon. The four main manifestations are death, teratogenesis, malformation, but also maybe growth retardation and functional deficits. So please read this at leisure and consider in particular the importance of alteration of growth, hemihypertrophy, the growth failure of children with Down syndrome, and so forth. All the examples mentioned previously relate to concentration, peak doses, and duration of exposure. Alcohol is a particularly good example because it is binge drinking that is the peak dose, and the repeated peak doses are the factors that determine the spectrum, the very wide spectrum of fetal alcohol impacts. It depends when, and it depends for how long. The same applies to strontium or cesium, and for instance, the physical half-life of cesium may be 20 years, but once incorporated in the body, it gets excreted in about 1 year, the half-life. But if it is bound to a cell that is, let's say, eternal, that will not divide thereafter, that little radioactive element will be releasing energy and breaking structures in its vicinity for as long as that cell in that tissue is contaminated by a analog called cesium-137. Consider these points. And finally, the sixth principle underscores that the manifestations of deviant development may differ in function of degree, dosage, and duration of exposure, but there may be no detectable effects to total lethality. So the concept is then the threshold, something that scientists have to consider, in particular when performing experimental studies or epidemiologic analysis. That frequently requires the application of dose response curves. And when there is a dose-related increase in teratogenesis, that's one of the strongest proofs that a medication or other risk factor is teratogenic. In the next frame, we are going to show you all 6 principles, and I will continue there. So we have reached the end. Here are the 6 principles for you to review and to try to remember when you see a patient. Is the patient very susceptible? Is it susceptible because of the genotype or because the environmental factors are terrible? Is it because it was exposed very early or even before implantation? Or is it because the exposure is continuous or has peaks and valleys? Is it related to some function, although you cannot see a structural anomaly? Certainly some children of alcoholic mothers will have terrible behavioral deviations, and yet the physical manifestations may be minimal. So consider these points because they are directly relevant to an analysis of a child with developmental disabilities. I will end by saying that dysmorphology is a subset or a discipline related to teratology that views these principles in the context of the clinic. And I presume most of the listeners are potential or real clinicians. Thank you for your attention, and I invite you to see the tutorial concerning drugs, concerning prescriptions. Thank you again. And so we have reached at the end of this first of a 4 webinar series, and I remind you that to obtain a certificate of participation, you should look at the supplement because it includes visual materials and other statements that are included in the examination required to apply for a certification.